Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a case of Desmoplastic Infantile Astrocytoma. So this is a case of a 5-month-old patient who was noticed by the parents to be irritable and frequently vomiting, and they've noticed as well increased head circumference. So they sought medical advice, and on radiological imaging, and this is the typical radiological appearance, as you can see here on the left side of the hemisphere, a large cystic mass with a solid component that is brightly enhancing, almost occupying like 2/3 of the hemisphere. This is the typical presentation. This is the typical MRI findings of this tumor. So once seen, this appearance in this age group, the first year of life, you have to think of desmoplastic infantile ganglioglioma or astrocytoma. Now, the tumor was resected, and as you can see, this is the low power magnification, and as if the tumor has two halves. One half or one component is the small round blue cell tumor here, and the second half on the right side here is the pink tumor. Now, zooming into both components. One component is the small round blue cell tumor, or the embryonal component, that is composed of a small round blue cells, reminiscent of a neuroblastoma, peanut medulloblastoma, while the one on the right-hand side shows the cells with abundant acidophilic cytoplasm and some tendency at spindling here, again pink in color in general, while the embryonal component, the small round blue cell component here, shows the rounded nuclei, the neuropil in the background, and some vascularity. And again here, another focus from the tumor showing or contrasting both components. One that is a small round blue cell, showing here more in neuropil in the background, very much reminiscent of a neuroblastoma that we see peripherally, and here cells with abundant acidophilic cytoplasm. So if you remember, there were areas that were spindle, there were areas showing some cells with abundant acidophilic cytoplasm, and there were areas that showed this amount of cells with the abundant acidophilic cytoplasm, very much reminiscent of rhabdoid tumor, which is an important differential diagnosis that we should keep in mind, especially in this age group and with this appearance. Now, again, the embryonal component showed more and more evidence of differentiation, very much similar to neuroblastoma, especially the differentiating in neuroblastoma that we see peripherally with the neuropil or the cotton candy appearance in the background. And then we have the small round blue cell component, but also we're seeing some maturing cells, like maturing ganglionoid cells seen here. But remember, this component that I showed you almost always on the left side is the embryonal component, and this is another area of the embryonal component, and this is just to show you the sharp contrast with the normal brain. So this is, the tumor is usually well circumscribed, does not infiltrate the adjacent brain tissue, with a sharp edge between the tumor and the normal brain. Now, moving into the immunohistochemistry, and GFAP is usually positive in the glial or ganglioglial component, but is negative in the embryonal component. So the embryonal cells here are almost completely negative, while the ganglion cell or the astrocytic component in this example are positive. So on higher power magnification, this is where the embryonal component, I almost always showed you this on the left-hand side, it's almost completely negative, while the better differentiated, the astrocytic component, is seen on this side, showing the beautiful cytoplasmic positivity. Now, in contrast, the embryonal component shows the synaptophysin positivity because it's very much similar to neuroblastoma peripherally, to the peripheral neuroblastoma, while the astrocytic component is completely negative. And again, chromogranin A is positive, patchy positivity in the embryonal component, while it's negative, completely negative in the astrocytic component. And the Ki-67 proliferative index also contrasts between both components. So we have the embryonal component with Ki-67 reaching to 30–40%, while the better differentiated astrocytic component is showing like 5% positive Ki-67 proliferative index. Remember that the astrocytic component poses this very much resemblance to ATRT. This is why it has to be excluded, and I1 immunohistochemistry showed retained nuclear stain in this component, thus ruling out the possibility of atypical teratoid rhabdoid tumor. So to sum up, the final diagnosis in this case is desmoplastic infantile astrocytoma. Sometimes within the astrocytic component, we might find some ganglion cells, then we will call it desmoplastic infantile ganglioglioma. But regardless of this component, there will almost always be an embryonal component that is very much reminiscent of a neuroblastoma that we see peripherally. Remember that this tumor, despite the presence of the embryonal component, behaves in a good fashion, especially when treated properly with the chemotherapy, and this is assigned a WHO a grade 1. Remember that radiological appearance is very characteristic, a huge cystic tumor with a solid component, and the solid component shows the embryonal component that is reminiscent of a neuroblastoma, usually positive with synaptophysin, while the astrocytic component in the case of desmoplastic infantile astrocytoma, or the ganglioglioma component in the case of desmoplastic infantile ganglioglioma, are seen on the other side on different areas and usually are positive with a GFAP immunostain. I hope you find this tip useful in your daily practice. Thank you.